welcome to this yet another video on the inpatient management series of hyperglycemia. Chapter 2, in this we discuss the monitoring and glucose targets. So you have previously saw the chapter 1 on the introduction to hyperglycemia management in the wards. Uh, from this video, we'll see how to start initiating insulin therapy or what criteria to initiate insulin therapy and how to manage the hyperglycemia in the wards in a brief, short, bite-sized video. So why monitor? According to ADA, endocrine consensus, inpatient monitoring exists to identify hyperglycemia. We need to catch the spikes that require treatment. So initiate on admission or if known diabetes or random glucose more than 140 milligram per deciliter. Always check on HbA1c, distinguish between chronic and stress hyperglycemia, and to inform discharge planning. So again, even stress hyperglycemia should be treated with insulin therapy in hospital hyperglycemia management. So always safety is the priority, hence prevent hypoglycemia. Hypoglycemia is more dangerous than hyperglycemia. Safe titration. Provide data to adjust insulin doses. So what to measure? CBG, capillary blood glucose monitoring. It is also called the point of care blood glucose monitoring. It is a primary tool. It is fast, bedside, used for day-to-day management and insulin titration. It requires validated glucometers as every hospital has validation criteria. So the lab plasma glucose used when POC is inconsistent, essential during shock, post-perfusion, edema, hypotension, or for diagnosis of hyperglycemia. So it is a general rule that lab plasma glucose value is 10 to 20 milligram per deciliter lesser than the capillary blood glucose, as the capillary blood glucose is measures the plasma glucose, whereas the blood glucose and the lab plasma glucose is 10 to 20 milligram per deciliter lesser. Always check on ketones or arterial blood gas analysis to look for the pH changes or anion gap or the bicarbonate levels in extreme hyperglycemia of more than 250 to 300. Also measure urine or serum beta hydroxybutyrate if available to exclude DKA. Frequency of monitoring in wards or ICU. Eating patients, standardly we use 3 meals plus bedtime. 3 meals before every meal, that is pre-breakfast, pre-lunch, pre-dinner, and usually at 10 p.m. It provides 4 actionable points for basal bolus titration of insulin. In an NPO patient, internal feeding patients, on total parenteral nutrition, the standard is to monitor every 4 to 6 hourly. It is required because feeding is continuous or unpredictable in these kind of patients. In ICU, it is the IV insulin that is preferred and hourly monitoring is preferred. In phase 2, Q second hourly once stable as per protocol. Basal only regimen, only pre-meal checks are sufficient. So glucose targets by setting. According to American Diabetes Association, it is the 100 to 180 milligram per deciliter in non-critically ill ward patients. This is standard for most patients. Individualized if easily achievable without hypoglycemia. So in critically ill patients, it is less strict. It is 140 to 180. This is to avoid the diet control due to hypoglycemia risk. Use IV insulin for better titration. Note on for frail and elderly patients, you can relax the targets up to 200 to minimize hypoglycemia risk. Thresholds for treatment, less than 140, just monitor. More than 180, initiate insulin. And severe DKA, escalate to IV insulin therapy. So hypoglycemia, we have to very carefully monitor for hypoglycemia, which is more severe than hyperglycemia. So hypoglycemia has more detrimental effect as well as causes poor prognosis of whatever illness the patient has. So hence it is utmost important to prevent hypoglycemia in ward admitted or IC admitted patients. The alert value is glucose is less than 70 milligram per deciliter is called hypoglycemia. Clinically significant if glucose is less than 54 milligram per deciliter. Severe if the event is characterized by altered physical status, mental status, or any other neuroglycopenic symptoms like sweating, tachycardia, altered sensorium, drowsiness. Hypoglycemia treatment, we initiate treatment with, if the patient is conscious, we can give oral carbohydrates, 4 to 6 glucose tablets, or 15 to 20 grams of carbohydrates, or 120 ml of juice. Always recheck in 15 minutes. This is also called the 15-minute rule. 15 rule, 15 grams of carbohydrates, recheck in 15 minutes. Unconscious or IV access patients, you can give 50 ml of D50, dextrose 50% IV solution. Prevention strategy, always avoid sliding scale monotherapy. Best is to use basal bolus. Conservative dosing, start low in elderly or renal failure patients. You can also advise to take a bedtime snack if nocturnal hypoglycemia is existing. Missed meals, hold branded insulin. Ensure action plan is visible in the chart. such that the ward staffs can follow if there is hypoglycemia. Correction of sliding scales. Never use sliding scale as a monotherapy. The role of correction is when you use basal therapy as well as bolus therapy in pre-meals, then rechecking that capillary blood glucose at the time of meals. If it is higher, then you can give a prandial therapy according to the sliding scale. This is to correct the pre-meal hyperglycemia back to target. Safe application. It is weight-based scale aligned to hospital formulary. Insulin resistant. Use higher sensitivity scale if the patient is insulin resistant. HbA1c is one of the criteria for defining insulin resistance. More the HbA1c, more the insulin resistance. Elderly and CKD use lower sensitivity scale, less insulin per milligram per deciliter. So there is also another tech advancements such as continuous glucose monitoring scheme where you place a monitor or sensor in the skin of the patient that checks the blood glucose throughout the day. It has an emerging role. Limitations always validate with point of care during shock, hypotension, poor perfusion. It does not replace the POC yet. It requires a strict local policy and staff training, clear algorithms for acting on trends and errors. The advantages is that it can detect nocturnal hypoglycemia and 24-hour glucose variation, and the our insulin therapy can be titrated according to the 24-hour glucose variation to keep the time in range as far as possible. Special monitoring situation, as we discussed previously, if the patient is on enteral nutrition, monitor the blood glucose 4 to 6 hourly, use basal plus correction or IV insulin, coordinate feeding interruptions with insulin hold. If the patient is on steroid therapy, there you can always expect diurnal hyperglycemia, especially in the daytime where the steroids is being given. So you can always add NPH or postprandial insulin. Monitor pre-lunch and dinner closely. The patient is on total parenteral nutrition. Again, check every 4 to 6 hourly. It requires regular insulin added to the bag or separate IV infusion to prevent hyperglycemia. And again, renal failure patients, dialysis patients, glucose swings during dialysis. Monitor pre and post dialysis, reduce insulin doses. Try to avoid these prandial doses of insulin if the patient is on dialysis or on the day of dialysis. So this is the practical order templates that you can write in the ward occasions. In a patient who is eating well, you just ask to monitor pre-breakfast, pre-lunch, pre-dinner, and at bedtime at 10 p.m. preferably. Targets, pre-meal is 100 to 140, random is less than 180. If there is more than 180 persistently, go for a basal bolus therapy. On NPO and the enteral feeding patients, monitor CBG Q4 hourly. If the feeds are interrupted, hold prandial insulin, give 10 to 20 gram carbohydrates per oral or 10% dextrose IV to prevent hypoglycemia in NPO or enteral feeding patients. So hypoglycemia or protocol, this is the way you have to write in the case sheet. If the CBG is less than 70, give 4 glucose tablets or 120 ml of glucose, recheck in 15 minutes. If the CBG is less than 54, which is severe, or if the patient is unconscious or having symptoms of neuroglycopenia, give 25 ml of 50% dextrose IV. Always notify the higher authorities or registrar in the wards. Reduce insulin dose by 10 to 20% for the next 24 hours to prevent further hypoglycemia. Documentation is very, very important in management of glycemic control to prevent infrequent or irrational insulin therapy to prevent any other hypoglycemia or hyperglycemia. It is preferable for a single person to give diabetic advice or the insulin therapy advice for a single patient. Quality metrics, hypoglycemia rate, which is the percentage of readings in target in range, is required for the quality metric analysis. Use metrics to guide local protocol refinement and staff training in your specific hospital. This is the last and final slide. Quick reference, the take-home points. When to monitor, if the patient is eating, check for pre-meals and HS, that is 10 p.m. If the patient is on NP or enteral feeding, check Q 4 to 6 hourly. IV insulin hourly. Hypoglycemia, treat if less than 70 promptly. 15 grams of carbohydrates per oral or IV dextrose. Targets, non-ICU, 100 to 180 milligram per deciliter. If in ICU, 140 to 180 milligram per deciliter. Individualized for elderly patients.